All right. Ayla, I'll turn it over to you if you want to kick us off. Welcome everyone to today's webinar, Navigating Volatility and Uncertainty in Revenue Cycle Operations, a path forward for business continuity, staffing flexibility, and cost restructuring. I am Ayla Ellison with Becker's Hospital Review. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We are looking forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. At this time, it is now my pleasure to start today's webinar by turning it over to our presenters to introduce themselves.
Excellent. Thank you so much, Eva. Good morning, everybody. My name is Victoria Hall. I am with Alpha Health, and we are honored today to be speaking with 4 industry leaders with very different perspectives on the impact of the pandemic and how they'll be preparing for radical shifts in the revenue cycle and patient volumes as we all return back to the new normal. I'd like to welcome our speakers, and they'll each introduce themselves. Today we'll be listening to Malinka Waliabe, co-founder and CEO of Alpha Health, Dr. Albert Chan, Sutter Health VP of Chief Digital Patient Experiences, Jeff Francis, VP and CFO of Methodist Health Systems, Greg McCurdy, Chief Information Officer of Hill Physicians Medical Group. And with that, I will just share our agenda today. Each of our guests will be introducing themselves quickly, and then we're going to get into a really interesting, thought-provoking discussion about some of the impact that they've seen because of COVID-19, but also how they're going to be hardening their systems and learning from their best practices that got them through this event. And with that, I will go ahead and introduce Malinka.
Terrific. Would you like to Thank you, Victoria. Yeah. So prior to Alpha Health, I spent several years as a partner at Andreessen Horowitz, or A16Z, which is a venture capital firm based in the Bay Area that manages about $10 billion in assets under management. I helped start and build out their healthcare practice there. I worked on about 20 investments across providers, payers, biotech companies, and healthcare technology companies, totaling about $250 million in total invested dollars. And it was through my time there and a number of other experiences that brought me to recognizing that we could use modern technology in a fundamentally different way to transform revenue cycle operations. So that's a little bit about my background.
Awesome. Thank you for
sharing. And I'll turn over to,
Dr.
Go ahead, Victoria.
Good morning, everyone. I'm Albert Chan, Chief Digital Patient Experience at Sutter Health, and I'm responsible for leading digital transformation across our enterprise, and really happy to be here. And let me hand it over to Greg Smith, to Jeff Francis. Sorry.
Thanks, Dr. Chan. Jeff Francis with Methodist Health System. Been here about 4 years. Prior to that, I was CFO at Ministry Healthcare, based out of Milwaukee, Wisconsin, and then also Parkview Health in Fort Wayne, Indiana. So thank you for inviting me, Malinka.
Oh, Greg, I think we lost your audio. Of course, we had it working all the way up till 2 minutes ago.
All right.
Hi, good morning, everybody. My name is Greg Smith McCurdy. I'm the Chief Information Officer for Hill Physicians Medical Group in Northern California. I've been in healthcare and IT for about 35 years now, previously at Sutter Health as the CIO for Shared Services.
Awesome. Thank you very much. And with that, we will go ahead and get started. Some of the key learnings we're going to be looking at today. will be how automation in operations can provide continuity during volatility, strategies for protecting your teams and supporting them through this, and how to think about mitigating financial risk for your health payers and manage through the instability. And with that, Malinka, I will go ahead and turn it over to you.
Great. Thank you, Victoria, and to our panelists for joining, and to attendees for joining as well. We've got a fantastic perspective from very different healthcare executives from very different parts of the organization, all bringing to bear what their learnings were from this environment. A quick snippet on Alpha Health. At Alpha Health, we use modern technology and machine learning to automate revenue cycle operations. You can learn more about us at alphahealth.com. But with that, the format of this discussion today is we will ask some group questions up front, where they'll be directed at all the panelists. And then right after that, we're going to ask some one-on-one questions to individual panelists. The other panelists are welcome to jump in if they have perspectives as well. And I will as well, as a moderator, offer some perspective for some of those questions. So with that, for the first question addressed to all the panelists, what were the greatest impacts that this pandemic, COVID-19, had on your organization, both in the near term and the long term? And we can have maybe Greg go first, or we can go in the same order that we introduce people. Albert first, Jeff, and then Greg.
I'm happy to go first. I think the biggest impact that we had was migrating to a remote workforce and doing that as quickly as possible. I think, we had very little notice in the process of doing this in California, maybe a couple of days, and making sure that the organization had the capability not only to move to a remote workforce, but also to have the ability to collaborate across the workforce. We had business continuity plans in place, but had never really had the opportunity to fully test them out. And I think that one of the other challenges was that some of the major vendors that we use to collaborate with, such as WebEx and Skype and so on, and in the medical, certainly in the medical field with telemedicine and video visits and so on, some of them had not really had the opportunity to fully flesh out some of the technology capacity issues that they might have in a situation like a pandemic. So those are the major issues that we seem to solve pretty rapidly within the first week. But that was the big one.
Thank you, Greg. Albert, Jeff, perspectives from you on this question.
Thank you, Malinka. So I would say from a care provider's perspective, since I am one, I don't just play one on TV. What was tremendous was the clinical transformation that happened. As Greg mentioned, probably the most prominent one for me was the adoption of virtual care or telemedicine. We have been trying to do this for many years. We averaged prior to COVID, we averaged about 7,000 video visits per year, so a very modest amount. With the transition to COVID, we saw a max of 7,000 video visits per day. And it was a tremendous expansion and rapid implementation. So we had a 2-year plan that we had put in place to roll out telemedicine, and we actually completed that rollout in 4 weeks. So 4,700 clinicians in 4 weeks' time were able to then do virtual care. And what's been amazing is both the rapid adoption by our patients and also the rapid acceptance of this new technology approach by our clinicians. And I think that's probably the most prominent measure of our success in being able to do that in this new way is our Net Promoter Score. So we had an opportunity to look at our first 9,000 patient satisfaction surveys at Sutter Health, and we received a Net Promoter Score of 83. So it just strikes me about this can-do attitude, these things that had historically been difficult to deploy quickly, and just the expectation of our organization is to change much more rapidly than we ever thought we could do in the past. So, and I think this is going to hold lessons learned for us going forward about the pace of change and what we need to do to meet the demands of our patients. Jeff?
Yeah, and no surprise for us. I mean, from my perspective, it was really the concern, the impact of loss of cash. We weren't going to be impacted immediately because we have days in AR of about 45, which means that if we don't have a surgery, like we had the suspension at our location of the elective non-emergent surgeries the end of March, we wouldn't really see an impact on cash until the end of May, beginning of June. But knowing that we were going to have to spend more money to protect our employees, protect our first line caregivers, take care of the patients, and then anticipating a surge that really never occurred, thankfully, in Omaha, at least not yet. It was the focus on the cash and the daily monitoring of revenue that it was going to impact in the future. And so what we did is we immediately took advantage of the CMS advanced payments, brought down a good portion of that, and thankfully we've been able to just keep that in a bank account and have not had to tap it. So again, it was around that cash need.
Got it. Thank you.
I'd like to add a little something. I agree with Jeff. One of the things that we had to deal with as an IPA is making sure, as the number of visits were decreasing in the physician's office, we had to make sure that we were taking care of our group members because their cash was going down. So looking at how we might release incentive programs a little bit earlier so that we could maintain their livelihood during this significant reduction in office visits that were going on. That was a top priority for us.
Makes sense. And actually, as with any good webinar, I'm now coming up with questions that are not on the slides based on what you all just said. There was a really interesting perspective. I think, Albert, you brought that. I think it's worth asking everyone here is, at many health systems, we are well aware that the pace of change is often not rapid. And it's for good reasons, right? There's a lot of risk involved, and it's very important to recognize that risk and make sure to validate anything being brought in. But I think through this period, what a lot of people realized is we can do hard things a lot quicker than we thought because we had to. I'm curious how different groups at your organizations responded to that realization and what it's done to the mindset of bringing things in quickly moving forward.
So I'll take that one first, Malinka. So I want to quote a great poet, our modern poet, Lin-Manuel Miranda, right, of Hamilton, who has said, "I'm not gonna miss my shot." I really do think that our organization has adopted a pace of change that's truly remarkable. So instead of, with all due respect to our great organizations, there always seem to be reasons why not to do something, right? There are always concerns, of course, and healthcare is a conservative industry, rightly so. But I saw a new spark in folks' eyes, virtually, of course, that we thought about how could we get things done. So in the telemedicine example that I gave you guys, we had over 200 people throughout Sutter Health, again, all distance, because we were all sheltered in place and working from home and so forth. But we all got together, many people that I'd never met before in my entire life, despite being at the company for 18 years. And yet we all came together for a common purpose. And we all, in our different roles and different capacities, said, how do we make this possible? So for the telemedicine rollout, for example, our IT colleagues, they spent nights and weekends readying iPad. We decided to deploy iPads to make it easier for doctors to do telemedicine. And so, 4,000 plus iPads, days, nights, weekends, they were provisioned. And then we essentially virtually enabled those technologies and then deployed them. We never thought we could do it, but we did it, right? And it was amazing, all within a matter of weeks. And it's this can-do attitude that we're now pushing ourselves. So we now have our meetings, and as we find ourselves slipping back into our previous ways of doing things, we say, no, wait. So how can we get this done in a matter of days and weeks, not months or years, as we used to think? It's been remarkable. It's remarkable.
I love that unique perspective.
At a Methodist, I think the best example we had our first case present one of our EDs on a Friday, and by Monday morning we already had a call center set up to handle queries from the public to see if they needed to go into the emergency room or to go to one of our testing sites. And so what I really learned from that is we started trusting our subject matter experts and letting them handle it immediately, as opposed to maybe in the past we would have had more of a collaboration, more of a group, trying to get excellence by committee, which doesn't always happen. But that was probably the biggest one, where we had that quick turnaround, had a great expert within our system that had done call centers in the past. We let him do what he can do the best, and it was up and running. And so early on, we were able to keep about 4 out of every 5 people that called in out of the ED or out of our testing sites, so that we could focus the resources on those that were really in that immediate need early on.
That is fantastic. Amazing perspectives there, both. Greg, I'm curious if you have any thoughts to share as well. Otherwise, happy to move on.
No, I think moving on is okay.
Sounds good. The next question we had for the group was, what are the priority investments you are making today that will ensure your organization's resiliency going forward? And Greg, maybe we'll have you start, and then Albert and Jeff. Sure.
Automation is something that is a mantra for me. As we moved from the office, it became quite apparent those things that we couldn't do without either being in the office or some coordinated effort. So we've used a lot of this time to look at how we would apply automation to some of the major tasks that we do. Definitely need to continue to do that as we try to lower our administrative expenses. We experience some barriers in terms of operator resistance, but healthcare is a little bit behind the times in terms of moving away from manual processes to more efficient automation, trying to get people to understand that reductions in workforce don't necessarily mean that we're moving people away from healthcare. What we're trying to do is get people to a higher level. So we're going to spend quite a bit of time during this pause, so to speak, to look at how we could automate things a lot better. Additionally, we're really doubling down on telemedicine efforts. As we keep talking about looking at opportunities to use telemedicine outside of just the office visit, but move it more into care management and other areas of the organization where we've been talking to people via phone, and we'd rather talk to them on video, and it gives a much more personal experience, especially in the areas of things like SDOH, social determinants of health, having a visit during this time when people are so isolated. A video visit, if it's possible through a phone or someone, is a really great opportunity to to extend that personal touch during a time of crisis. So now that we've got that, as Albert said, sort of, we're not going to miss our shot. As people are getting more aware of how video technology can come into play and how they've been, touching base with their families through video. This is a really, really good opportunity to move some of our business away from just phone calls into a video environment and get a better response.
Thank you, Greg. Albert, if you already happy to turn over to you.
Sure. So I'm going to invoke additional geeky comments because you guys can all imagine I'm a little bit of a geek. No surprise. So I think we are making investments to fully take advantage of the space-time continuum, right? For those who know that phrase. Ultimately, in the path forward, it is clear to me that we're going to need to be much more nimble. People are going to be even more important. The intellectual capital that we have is going to be even more important to leverage appropriately and wisely. And we have to be able to span multiple time frames, multiple geographies. So for example, as an example of geo arbitrage, we have a service center in Utah that can service patients at a different time zone than ours and leverage their talents, but be able to provide the same level or better level of service than we did previously. We are offering, as we've ramped up our digital engagement, we've ramped up our capabilities to support our patients. Patients still have their support needs, so we have essentially online services service desk that serves our patients 12 hours a day. And again, they don't have to be in California. And actually, that geo arbitrage allows us to leverage people in different environments, mostly remotely, and still be able to service our patients' needs. As Greg has mentioned, we're really doubling down on automation as well, leveraging machine learning, artificial intelligence modalities to try to service patients in new ways. So, for example, we offer services where you can actually have a digital conversation with a robot to discuss your symptoms and get navigational advice about what level of care you need to seek and in what time frame. We're looking at AI to help in the assessment of radiology studies to do quality assurance to avoid errors. And we're making big investments in self-service modalities that we think will improve the experience of care for the patients and make it more sustainable to provide care by our organization. So the ability, for example, to self-schedule your own appointment, to be able to discuss with a bot or even a conversational agent, to be able to manage many of the traditional transactions that you might need to do. This will allow our organization to be able to scale up the human capital we already have to use for bigger and better things, to be able to concentrate on care delivery, and yet still be sustainable from a organizational perspective. Jeff, love to hear what you have to say.
Yeah, and I'll focus investment-wise and talk a little bit about the supply chain. Obviously, we got caught from PPE and some other areas. And from a CFO perspective, we wanted to keep our inventory as low as possible. And so really practicing just in time. But now what we need to do is we need to have just in time with the low par volume, and also just in case. So we need to start building that strategic stockpile on the PPE. But it really doesn't mean that it needs to be just focused on the pandemic. What we're looking at are the different types of scenarios where we would need some additional supplies, and then making sure that if we need that type of supply across all those scenarios, then that is one that we want to put in that stockpile and start managing that on a just-in-case basis. That's going to take away money that would be invested, or some of that because it's eating into working capital, but it's just something that we'll need to do going forward.
Got it. Thank you all. Very, very interesting and very different perspectives from the group. Something we have heard actually from a lot of our conversations is the perspective on increasing the level of automation at different organizations. As folks going through this recognize, we're going to be facing an increasingly volatile environment for quite some time. And how do we make the best use of our human capital? How do we have everyone across the board, including in areas like revenue cycle, work top of license? And obviously one key way to do that is with automation, to minimize any sorts of the amount of manual work that you have to do. So switching over into more targeted questions. So this is a question for Dr. Albert Chan, and of course, Greg and Jeff, please feel free to jump in if you have perspectives here as well. Can you speak to the operational changes in the delivery of care before, during, and after this pandemic?
Sure. It's a $64,000 question, right? So what has changed since COVID? First of all, let me just wish everyone in the audience that you remain safe in these troubling times. I think that is first and foremost the topic that myself and other leaders of Sutter Health are concerned with. So how do we care for our communities and for our care teams that are, remain committed to taking care of people on the front lines, to take care of folks. And no more, with that goal in mind of safety and continue to care for people, I think that informs the operational changes we have made. So we've had to become much more nimble, much more flexible. We had to stand up, for example, respiratory care clinics where to reduce the need for PPE. Jeff mentioned the protective equipment shortages the nation has had. We've had to stand up very quickly respiratory care clinics that were led, ironically, by a dermatologist and a neurosurgeon. Let me just point that out to my clinical colleagues. That's interesting. They stood up a respiratory care clinic where patients could drive up in their cars to be interviewed and get respiratory testing for COVID. An example of nimbleness, an example of ingenuity, and trying to be much more flexible about how to deploy human capital to take care of people. That was, to me, one of the great examples. And we've seen, as I already mentioned, we've really seen a tremendous pace of change in operations to support these safety initiatives that we want to achieve. So, for example, we're now, and the importance of technology in that, playing a role in that. So, for example, we are now using geolocation and GPS technology to offer our patients contactless check-in. So the idea is, historically what you would do is sit in the waiting room, breathe in the air of everyone, answer your paper-based questionnaire, and then wait for the doctor. Now you can do this contactless check-in where you can do this from your mobile phone, answer those questions at home, fill in all the information the doctor needs. When you drive up to the clinic, we auto-detect that you've arrived and say, are you indeed arriving for your visit at 9 o'clock? Click here and walk to your doctor's office. You can imagine the avoidance of the waiting room and other things. This contactless check-in is a great idea, but it was only made possible with a unique understanding and nimbleness of clinical and operational workflows that folks were willing to adopt change. Willing to say, we don't have to have our patients come to the front desk as we used to do. But let's push these things online. Let's push these things at home so people can do it at home more safely. Another example is documents. So my legal colleagues have been great to try to put in new changes to help increase the safety of the organization. And here's an example: wet signatures. So we had a common understanding that we had to have paper-based forms, our grubby little hands on paper-based forms to sign documents and hand them in. So we've now rapidly adopted the ability to now e-sign those documents, again, to avoid the risk of infection by exchanging forms. We're enabling our patients to submit clinical images. So I had a story of one of my colleagues the other day where An email went out from a primary care clinician to a primary care clinician. The primary care clinician, within a few hours, read the email, referred that patient to dermatology. With this new technological approach, asked in preparation for a video visit to please submit some images of the mole in question. And instead of taking weeks or months to get a referral to dermatology and get evaluated, within less than 7 days, the biopsy was performed and diagnosis was achieved. It's transforming. The way our operations are working today is just transformative, and I just hope, my big hope and my big worry is let's not settle back into the way it used to be. So my hope is that our operational changes that we've adopted for today to respond to COVID have long-standing changes in how we conduct business, how we think of ourselves going forward.
Thank you. I'll move on to the next question here with Jeff, I believe. Jeff, what steps did you take to maintain continuity and build resilience as you, so these are two questions, I'll ask them separately. What steps did you take to maintain continuity and build resilience as you moved to fully remote revenue cycle operations?
Yeah, and due to processes and some of the technology, we couldn't move fully remote. So those that we could did, but we still had paper checks that were coming in that would need to be handled and deposited. So those that were at home or working from home, you know, we had the daily huddles. We had actually more interaction than we did a year ago because we wanted to make sure we had that presence and being able to reassure the staff. The other is during that time we were, not a plug, but it's true, we started moving with Alpha Health about a year ago on some robotic process automation. And that allowed us to continue to check the status on claims 24/7. So even while people were moving, adjusting, not being as productive during that time, in the background, we were still able to monitor that. And it was a great benefit to us. We had our yield on the payers maintained. They didn't degrade during this time frame. We actually have seen an improvement over the last 6 months because we've had our business office staff work at the top of their license. In an example, because they were focusing on the more difficult ones as opposed to spending time checking on the claim status that was being automated in the background.
Thank you, Jeff. Yeah, one of the things we noticed and was that, I mean, through this environment, we in our conversations, a number of different revenue cycle leaders and leaders in different departments, as folks switched to a fully remote environment, all of a sudden, people really didn't have time to prepare or plan. And in many areas, folks' output could decrease. And in those cases, the way to have real resilience is if your workers really live in the cloud and can perform continuously day in, day out. It's something we were enormously proud of at Alpha Health to be able to provide, where you had a continuous system that was always functional and could always be the backup to any sort of disruption to staff. As a next question, Jeff, what is your plan to manage? There's a lot of new financial pressures being created. I think we've all seen that at every one of our great institutions represented here. How do you think about managing these new financial pressures created in this environment?
Yeah, it's going to come back to the efficiency and just trying to understand and operate on a lower cost structure. That's probably the biggest item. And then everybody will have some type of metric that they'll have to hold themselves accountable. So from the revenue cycle side, we look at things from a cost to collect. So simple metric, expenses divided by cash brought in. So to the extent that we can reduce the cost or bring in more cash, we're going to be able to do that more efficiently, and then that's going to be able to put the dollars or keep them into the patient care, which is why we're here. We don't want to take a larger slice of the pie by being a more expensive back office function.
There's
automation, any of those types of areas that we will look at, but it's always around that lens of how do we reduce that cost to collect.
There was you and I were just chatting on this recently. There's a thesis we've been thinking about around in healthcare. There are so many massive fixed costs that we as an industry would be served better if we could be a lot more nimble and convert many of those fixed costs to variable costs. And then we can look at the technology industry as an example of an industry that did that really well. They moved many of their massive costs were these massive computers, these massive servers that they needed to buy ahead of time and keep paying down on. And then across the last decade or more, what the technology industry has done is convert many of those fixed costs to variable costs by going to the cloud, right? So they rent cloud servers, which means that they can align their costs much more directly to revenue. Because one of the big challenges I think we all had during this pandemic is revenues dropped significantly, but we could not drop costs as significantly, and that of course creates enormous challenges. And so I think what we now have the opportunity to do is like really think about what are those massive fixed costs that we have, and then how can we think about converting those to variable costs? And of course, automation is a pretty traditional way of doing that, where you have the ability to scale up very quickly depending on revenue or demand, and scale down very quickly depending on reduced revenue or demand. And Jeff, you had a really interesting analogy that I'd love for you to share to the group if you're open.
Yeah, and so as we talked about it, I have a math background, so I tend to put those into type of perspective. So from an algebra standpoint, you would have larger steps. And what we really want to do is going into more of that calculus view, more of a smooth line to really get that differential down so it's very incremental, being able to operate in a more elastic manner. So don't know if that comes across as well in this connotation, but definitely moving away from those larger, the example of, just renting a little bit more RAM as opposed to bringing in a full server. That's a huge change, and allowing better cash management through that as well, because you aren't doing the large capital outlay that you want to depreciate over years. You're renting it, you're using it now, and being able to handle it in that manner. Exactly.
I love the analogy. I think we're all somewhat geeks on this call, and probably many of your attendees as well. It's a terrific way to think about it, because this is the time where we can learn from those other industries like the technology industry, and we have the opportunity now, because we have the need now to actually truly think about converting many of those large, because it creates very bad incentives too in the healthcare system, right? Because when we have these giant fixed costs, our incentive is to try and leverage those fixed costs by bringing in as much patients and procedures as possible. So this is by being able to convert to a more variable cost basis, I think it'll create much better incentives in the system. So I'll move on to the next question, unless folks, the other panelists had any thoughts on either of those fronts. Okay. Greg, this was more for you. How do you plan on deploying and operating technology solutions remotely in this environment?
Yeah. So day one of the shelter in place, we had a lot of implementations that were in flight. And, the question always comes up during that time period: should we take a pause on these things and wait until we can come back into the office? And I think that, just the fact that we're in healthcare, and a lot of us had a good understanding of what the meaning of pandemic was, and the reality that was facing us in terms of were we going to be able to get out of this anytime quickly. We quickly recognized that we weren't going to be in a position where we could just stop implementations. in certain areas where we needed to interact with people on an individual in-person level. That was something we needed to slow down. But in fact, we were in the middle of doing an implementation for a new technology within the organization and decided to just continue on, but do it through cloud and do it on a video format. So we were able to successfully do several implementations without having to get in the room together to do it, not having to install new hardware in data centers, mostly through working with cloud technologies, working with video conferencing. There's a lot of things that we had to culturally get past, and I think that even video conferencing within organizations and even within healthcare organizations, I still think is pretty difficult to do. There's a lot of cultural issues around people stepping over each other in conversations and causing other people to be quiet and not contribute and engage in the conversation. Video helps that considerably, but there's still a little bit of a challenge as people make that shift. And much like with video visits, even though that technology has been around for a while, there's a lot of shifting that needed to go on, and it shifted pretty rapidly. But it was a hard shift, but it was a hard shift that happened pretty quickly. So we continue to do implementations, and with no end in sight, we're planning many implementations between now and when we think we'll be able to open up our offices again. And then also with the idea that we may, when we do open our offices again, it may be in a very limited use. We're thriving in this remote work environment where people are still being very productive, and we're getting things accomplished. So I think there are a lot of opportunities for us to continue doing things that we've been doing, and even in this remote environment that we're doing it, and starting implementations, which you think would be challenging, is actually, I think, a little bit easier because you can include more people through video than you would in a physical room, and you can get more engagement through the process.
Thank you, Greg. Yeah, we've noticed that. I mean, it's now critical that we be able to do implementations remotely, and there are a number of different aspects that allow us to do it in a more streamlined fashion today. One of the things that we've thought about at Alpha Health a lot was in terms of how we deploy. Even before this pandemic, we had been deploying almost entirely remotely in the past, just because we thought that was the best customer experience. And recently, one of the things we're very proud of is we've been able to deploy, just I think a couple of months ago, our last customer entirely remotely, end to end, from beginning to production, without stepping a foot on site, which was something that we just thought was the best customer experience before, but now has become an absolutely critical function. And as Greg was saying, it's something we'll have to plan on doing for quite some time.
I think there's this reality.
Yeah, go ahead, Greg.
I think there's this feeling that you have to see people in front of you and touch them and be able to have them come. I remember when we were beginning our implementation of Alpha Health, we requested that you come on site. We wanted to make sure you were a real person, and some of that was just not trusting the technology, the old ways of doing business. And we don't have that luxury anymore. And I think that this sort of bump in our adoption is going to go a long way in reducing those administrative costs for everybody, vendors, the organizations that are implementing. I haven't had to pay travel fees for a vendor for several months now, and that has been a real help to us.
That's actually a great point. You're right. There were a lot of groups that, where the mindset is you really do need to come on site, talk, see, feel people out really to get a sense. But that can be disruptive to staff on site. And what we always started from in the very beginning, again, even before this pandemic, is we can do all of that remotely, and it is a better experience for the customer. It is far less disruptive, and we're now able to leverage that model in every deployment because it is now absolutely necessary. So we have, I think we've talked about some different aspects of the question that's on the screen right now across the last couple of questions. Maybe I'll switch to, in all the different, for everyone here, as we think about bringing new technologies to bear, I've talked to a couple of you about this already, but there's this very interesting perspective on how we evaluate new technologies. There's this strange dichotomy in healthcare where on the clinical side, on the front end of care, we often use a very rigorous academic lens to bring in new clinical innovation. We really look for the academic publications when we bring in new clinical innovation, and that's important, and that's like a very, very critical part of it. But for whatever reason, in many cases, we don't apply that same level of rigor to bringing new innovation to the back office of healthcare. And I like to think, that's one of the reasons, like American medicine is the best in the world, but the American healthcare system is not quite up there. So we've had years and years of vendors, for example, talking about their breakthrough AI or something along those lines, but not really publishing academically on it, unlike they would on the front end of care. And some of the things we're doing at Alpha Health is we really want to bring that rigor to the back office of healthcare as well. And just for the folks on the line, if you're interested, we've already started publishing academically about some of that work. We're publishing, in fact, tomorrow we'll be presenting some of the machine learning models that we developed at we were selected for a spotlight presentation at one of the top machine learning conferences in the world, ICML. But the question for this group is, how do you think about evaluating new technologies on both the front end and the back end of care? Albert, maybe we'll start with you, and then other folks can jump in as well.
Thank you, Malinka. I am so happy you raised this issue because this has been a pet peeve of mine for a long time in the industry. I think as healthcare leaders, I'm going to combine your previous question and this question. I think in healthcare, we have three responsibilities as leaders. Kinship, which is how do we take care of our people? How do we serve, in my case, the patients, providers, and the communities we serve? Fellowship, how do we create learning systems across organizations so we can work with each other like we're doing today to share lessons learned and learn from each other? And finally, scholarship. And this scholarship point is what you're highlighting, Malinka. So I've had the great, right? So I think for us to really understand what we're doing and understand what the impact is, we have to study it. I believe so much in this, and in fact, I spent a great deal of time doing research and publishing our digital health implementations. In fact, we had the great pleasure of working with Greg Smith-McCurdy, who's on this call, to publish work in JAMA, Network Open, about implementation of a fee estimator. So the idea in healthcare, unlike other industries, is it a heretical idea that you can know the cost of the care you're going to receive before you have it delivered to you? That seems like crazy in any other industry, but that happens to be the case in most of healthcare. So Greg and I partnered on a paper where we looked at the implementation of a fee estimator, because at the end of the day, that's the last experience you have as a patient. You have the great clinical care, you interact with this health system, and then you get the bill, right? So we actually looked at implementing a tool that enabled real-time fee estimation for our patients. And we learned some amazing things. You only learn amazing things by actually taking the time to study, right? To actually putting yourself through that rigor, just like a clinical trial, and study, did you achieve what you wanted to achieve? And did you get benefits that you wanted to achieve? So Greg and I studied this paper on behalf of Sutter Health, and we found that nearly 80% of our patients cited that the overall care experience, just by being able to provide fee estimation transparency about the care experience, improve their care experience at Sutter Health. And we also noticed we wanted to look at the impact on providers. So it turned out less than 10% of the providers reported any issues. The concern was, would this impact, for example, them getting more calls to their offices about procedures listed on the fee estimator and tools like that? we really didn't see that. All is to say that I firmly believe what Alpha is doing in this sense. You need to be rigorous about your approach. You need to firmly study both the objective data and the organizational workflow impact on our staffs and our teams. And so I can't recommend that highly, enough. We really need to do that to understand what the impacts of these technology implementations are on our systems, and actually to contribute to a greater learning system for the country as a whole. So why should we have to learn these lessons by ourselves in silos at our respective organizations? I think we should share our learnings with each other.
Thank you, Albert. Jeff and Greg, feel free to jump in. Otherwise, I can close out here and move on to Q&A. Terrific. Yeah, I mean, I think my request for everyone listening, and I think everyone here has demonstrated a great deal of rigor, not on the front end and not just in the front end of care, but at the back office of care as well. And my request for everyone listening in is ask for that. If you're looking to work with new technologies, if people are talking about breakthrough AI they're bringing in, ask for the academic publications that they have put out, so you can actually evaluate for yourself how legitimate many of that is. With that, let's turn to Q&A. I believe Victoria or the Becker's team will be asking us questions that have come up here in these last 10 minutes.
Yeah, thank you so much, Malinka. Oh, go ahead, Ayla with Becker's again. Yeah, I just wanted to thank everyone for the great presentation and discussion so far. Like Malinka said, we will now begin today's question and answer session. So please submit any questions you have by typing them into the Q&A box you see on your dashboard. And we'll try to get through as many as we have time for today. We've already had several questions come through throughout the discussion today, so we'll go ahead and get started with a few of those. In the first question that we have today, this question is for you, Albert. And this person is wanting to know, do you think in-person registration for clinical services will be significantly reduced in the future?
Thank you for the question. I'll frame it another way. Think about your favorite consumer experience you've had in recent days. Has that been in person, or has that been remote? What do you expect of your Amazon experience or shopping experience or other things? I think Malinka talked about the using people at the top of their license. I think we fail to use humans, our patients, for the top of their license in a sense, because they ultimately are the source of the information, and they are the ones who have the vested interest in getting the information right. So we at Sutter, for example, are doing a lot of work on trying to digitize the registration experience. So today at Sutter Health, you can actually be a novel patient to Sutter, interact with our website, pre-register, do all your demographics, insurance, other things, and then get a patient record. I do think it'll be important going forward to digitize these experiences for our patients, and of course that'll lead to better experience for the patient and more cost efficiency for all of us. So, and it may not be an either or. It may not be that you have less in-person experiences. It may be that you're able to expand your capacity in total overall, because your in-person capacity is the same, but your digital infrastructure enables new or greater customer interaction. That's the bet, and I'm sticking to it.
Thank you so much. And we've had several more questions come in, so we're going to try to get through at least a few more that we have time for before the top of the hour. The next question that came through is for you, Greg. And this person is asking, can Greg give some examples of the automation tools they are working on?
Yeah, sure. We have started to, there's two parts to this equation. One is I've been with Hill for about 11 months now. And prior to that with Sutter, where we were looking at how do we automate the revenue cycle. We've been looking at significant automations through Alpha Health in terms of not only just taking it from the perspective of what could we use RPA in order to assist some of these manual processes that we're working on that have predefined business rules, but also looking at how we apply machine learning and artificial intelligence to that, which for most of us, that's the holy grail of automation, is to try to write automations that will be self-learning and will allow us to minimize the amount of errors that come through automation just in general. In my tenure here at Hill Physicians Medical Group, we're starting to look at not only those kinds of things from a different perspective. Hill is mostly on the other end of that, on the payer side. And so looking at how to apply automation to claims processing from the inbound claim perspective. Again, a lot of those manual tasks have predefined workflows and business rules, but also looking at how we look at machine learning and automation to that. We're also looking at some of these IT functions that we have in terms of moving files around, examining files for certain types of quality-related errors. And I think that's you can find automations that will take files and move them from one location to another, potentially load them into a different system. Those things are out there and in major use. But actually examining a file, looking at lab data and looking at if data is, if the quality of the data is being received is within normal tolerances, what we would expect to see, and then alerting and monitoring. So a lot of the automations we're looking at are around a little bit more advanced than just taking data in and moving it around the organization, but how do we get at that wedge between defined business rules and applying machine learning and artificial intelligence?
Thank you so much, Greg, for walking us through those tools that you're currently working on. Looks like we have time for one more question today. And the next question that came through is for you, Jeff. And this person is asking, as we review the impacts of the revenue cycle, what radical shifts did Jeff identify or experience outside of moving more staff to work remotely?
That is probably the focus of getting into the daily cash and treasury management. I hate coming back to that item, but it was really that focus. How do we leverage trying to get a few more basis points out of our investments so that we can, again, use that for the patient care? It was rebalancing our portfolios to make sure that we aren't going to, or we're going to try to minimize the dips, and so that we can adhere to our investment policy statement. The one thing that we were most grateful for is that we started deleveraging and de-risking our pension so that we were not susceptible to these decreased interest rates. So again, a lot of it was just taking advantage of the unique time we're at with low interest rates and making the most of it.
Thank you so much, Jeff. I wanted to just take a moment before we close things out today. I wanted to turn the floor back over to Malinka to share any final thoughts or any closing points for everyone who is tuning in today before we end the webinar.
Thank you. I just wanted to thank our panelists, Albert, Greg, Jeff. Thank you so much for taking the time. Your perspectives were extraordinarily helpful, both to me and I'm sure to the audience as well, and to attendees. We appreciate you joining. We hope you learned some key insights from this from a lot of different perspectives. And thank you again. And to the Becker's team as well.
Thank you so much, Malinka, and Dr. Chan, Jeff, and Greg, all for sharing your insight today and walking us through the presentation. I also want to take a moment to thank Alpha Health for sponsoring today's webinar. Please enjoy the rest of your day, and we look forward to having you join us for future webinars.
And be safe and wear a mask, please. That's
Yeah.
my advice. Please wear a mask. Sorry, I'm still a doctor. Please wear a mask.
Thank you, Jeff. Oh, wow. All right.
Awesome. Thanks,
Albert, put your
everyone.
mask on.
Yes, sir.
Everyone's taking. All right. Thanks, everyone. Talk to you all soon.
Thank you.